For the record, Dr. Vern Saboe, representing the Oregon Chiropractic Association. And on a personal note, I've been in practice for 44 years now this month. Practice started by my father in 1956. I love what I do. I have no plans of completely retiring. I'm down to 3 days a week. I started in 2005. I love treating folks who have been injured or who are hurting, that many times they have been to many different types of providers or just haven't had their issues addressed properly. And I'm the one provider that actually listens, takes a proper history, and helps them. It's very rewarding work. And all of my colleagues feel the same way. So I'll get into this later, but House Bill 3490 returns full attending physician status to chiropractic physicians, something we respectfully suggest that was wrongfully stripped from us back in 1990 in the one-day special session and all the work comp reforms. No one questions that the reform was necessary. But in our opinion, and I'll show you what I believe is evidence of that, there was a misinformation campaign that basically smeared my beloved profession, and it was secondary to a few outliers, and I'll show you that. But really, in reality, House Bill 3490 is about injured workers. It's not about chiropractors. We don't need chiropractic. We don't need injured worker cases or work comp cases to be successful. We have lots of patients. It's the injured worker and what's occurring. So the first slide. So one of the values of MLAC is balance and fairness. I got to get glasses for far now. Gary's getting old. So to that end, about Oregonians injured on work, getting timely, respectful, and effective treatment and management of their injuries. And currently, that's not happening all the time. And part and parcel to this is a long-time issue of injured workers being what we call steered, coerced, forced to local occupational medical clinics, because essentially they're the only ones seeing injured workers in the medical field. And so in a direct violation of Oregon law, we've instituted several administrative rules regarding forms, Form 3283. It is now a form that's part of the 827. It says very specifically that you can see the healthcare provider of your choice. Your employer cannot select your healthcare provider. That was then a couple years later inserted in part of the 801 that the employers to give to the injured worker. And there's also a poster. The problem is none of it's being implemented. They're not being given these forms to indicate that they can see the healthcare provider of their choice. And just yesterday, case in point, I had a Albany Samaritan Hospital employee who was injured with when I think how he described it, a Hoyer lift failed. It was a 350-pound patient. There was 4 CNAs working, trying to maneuver this woman. I think they were trying to get her to the bathroom, and it somehow failed. And he basically caught the Hoyer lift or her and injured himself. He was told first to go to the emergency department. He did that. Then he was told to call Samaritan Occupational Medical Clinic. And this is the other thing, a delay. He was told he couldn't get in for 2 weeks. Well, he was already an established patient. I had seen him in the past. So he said, I can't wait. I'm going to see Dr. Saboe. I had another patient recently, first became a patient maybe 3 weeks ago, who it took 6 months for him to finally be referred to me and had really not received much of any kind of care. But to his credit, it was the Samaritan Occupational Albany Clinic. It was the physician sent him to me, but it was 6.5 months later. 6 treatments, he's 80% more mobility and 50% reduced in his discomfort. The other issue is not just treatment, but our restrictions now does not allow us to perform closing examinations on these injured workers. The great majority of them are left with no permanent damage or what we call permanent medical impairment. Unfortunately, our time runs out, 18 visits, 60 days, and so we're not around to do a closing exam, and the great majority, and Evo's on the line can correct me, but it was actually Safe Reps that told me this. The great majority of all closing exams are performed by independent medical vendors, IMEs, and there's a little inherent problem with that. In fact, the IME issue of being biased was got to such a point that in 2004, DCBS did a study, and in the executive summary, they stated that 52% of the IME physicians themselves said the IME system is skewed against injured workers. So that's not an ideal situation. It's not fair to injured workers. And then interestingly, the other issue is that the department is still using a hybrid of the third revised edition of the American Medical Association Guides for Rating Impairment. That was published in 1990. It's 35 years old. The rest of the physical medicine world has moved on. We've moved on to the fourth, fifth, and sixth edition, which was published in 2008. And we've moved from the range of motion model to the diagnostic-related estimate model. We know certain injuries have certain medical sequelae. So all of this is about fairness to injured workers and are being restricted, discriminated against, not based on any rationale, is hurting injured workers. Next couple slides. Go two forward, another one. Nope, back one. So part of the restrictions on us, I was speaking with the SAFE representatives the other day, and they made the point, well, if someone needs, so the great majority of everyone, we can take care of them in 18 visits, 60 days. They're not the problem. It's the smaller minority with more serious injuries, and on the spine, it's always the ligament involvement or disc involvement. They're not the problem. The problem are those, the great majority are not the problem. The problem are those with more serious injuries like ligament disc. And IVO made the comment that, well, they can be referred back to you from a medical physician. The trouble is, those don't exist. There simply is not medical providers that will actually see workers' comp claims because they're sorry for the pun, a pain. The administrative work, the extra time, the legal aspects of it are a deterrent. And so any of the medical providers that can refer back are at doc med clinics. Now, this was the access was a problem back in 2012. And yeah, thanks. I keep forgetting to do that. I can't see there. I can only see here because I got glasses on. So, and the access issue, this issue has been going on for a while now. This was a study prepared for Safe Corporation, prompted by the department, and they surveyed 5,000 potential respondents, 5,000 medical providers, basically asking them what their thoughts are on workers' comp cases. 77 of all the various medical professionals, specialties responded. 77. 445 chiropractic physicians responded. We want to be involved. We have the evidence base that supports that what we do works and that it's cost effective. And I'll get into that in just a second. So the conclusion in this survey was nearly 1 in 3 providers consider these patients, work comp patients, a burden or avoid accepting them altogether. And that's what we found. In fact, attorney after attorney, they cannot. Yeah, that's the next one. the chair said that there's no physicians out there to refer, to get the injured workers referred back for chiropractic care when it's necessary. And again, that's the minority. So, affordability. This is a synthesis of all the costs related peer-reviewed journal articles that was put together by Dr. Anthony Rosner, epidemiologist, head of the research department at the University of Western States, where they have a 4-year doctorate of chiropractic program. The evidence is overwhelming that when we're involved, especially with non-surgical spine-related musculoskeletal injuries and pain, we substantially reduce costs. And that's part of the packet. So this is the cost shifting. I'm not going to go into all this, but you can see the cost shifting. And one of the things that's not really listed on here, and I specialize in treatment of disc herniation. They have a specialized COG-7 flexion distraction table, got good evidence behind it, NIH evidence. And anecdotally, I can tell you that between 50 and 60% of the folks that have disc herniations and radiculopathy of pinched nerve root, either in the neck or the low back, I can get their radiculopathy symptoms improved enough to where they do not go on to surgery. That's a huge savings in direct surgical hospital costs, but indirect disability costs. So here's the thing we've never addressed.
Sorry, please continue.
There's this negative reputation environment regarding chiropractors and workers' comp. It's kind of an unsaid thing that has been going on for years, and so where does that come from? Well, we think we know. So I'm going to give a little history here of why that is. Now, this is a study that SAFE did, in-house data mining of 1988. This is before the reforms. This is just before the 1989 fiasco and then the one-day special session. This data showed that with our outliers, everybody's got them, and our low liars and our in-between liars, our case average was $706 versus medicine's case average. Now, unfortunately, that was never told. What was told by, at the time, Stanton Long, the president of SAFE Corporation, appointed by Governor Neil Goldschmidt, repeatedly in the media stated that chiropractic treatment, based on our study, was more than twice as expensive. And that was, if you look at the top left under medical doctor case average, $256. While the case average for chiropractors was $706 in 1988. That's a fact of more than 2 times as expensive. What they didn't tell you, that was just to see the medical physician. Back then we called them family docs, general practitioners. Now they're PCPs, primary care physicians. Well, by and large, with very few exceptions, medical physicians with back, neck, musculoskeletal injury, they don't do any hands-on treatment like we do with deep tissue work, spinal ablation, and so forth, which is highly effective. They do one of 2 things. They write a script for medications and or a trial course of physical therapy, usually both. Well, back in 1988, the case average for physical therapy, which is a direct medical cost that required a medical referral, was $550. Medications, which we pride ourselves on not giving, everyone's prescribing, we don't need to, is $200. Radiology, we take and read our own x-rays, was $200. So their case average was actually $1,206, right at that number. Ours included physical therapy. It's within our scope of practice. We do physiotherapy and physical therapy interventions, therapeutic exercise every day in our practices. We don't prescribe the drugs, take and read our own x-rays. So, but that story was never told. It was told it over and over in the lay media was that chiropractors are more than twice as expensive. Leading up to the special session, SAFE Corporation also claimed, and I'm going by the news article, reporting on the then Secretary of State, Bill Kiesling, that they had lost $50 million in 1988 and $10.3 million in 1989. However, an audit reported by the Secretary of State stated that SAFE had understated their 1989 earnings by 25 to 35 million. The accuracy of which I don't know. I'm going by this report citing the Secretary of State who did the audit. Now, this is important. You're just going by me tapping because I keep forgetting to say anything. You got it. So, this is important. This is from that blue study commissioned by or paid for by SAFE. Why doesn't medical physicians want to treat these folks? Well, the added administrative time was 69%, was the highest rationale. Additional administrative time. Keep that in mind for these next few slides. This is an interesting slide. I'll explain why I've got this in here. Racketeering. I mean, you think in terms of mobsters, right? I mean, you think in terms of organized crime. That's what this was for. And I'm just going to read this. Racketeering is a set of illegal activities aimed at commercial profit that may be disguised as legitimate business deals. Racketeering is defined by a coordinated effort by multiple people to repeatedly earn a profit, typically by fraud, extortion, bribery, threats, violence, or other illegal means. That's racketeering. The Racketeering Influence and Corrupt Organization Act, RICO, is the primary law that outlines and criminalizes racketeering activities. Examples of racketeering actually may include money laundering, drug trafficking, or other forms of organized crime. Keep that in mind. This is a sworn affidavit notarized by consumer advocate, plaintiff attorney, now retired, Dan Gaddy Law Firm. And I'm just going to read this. This was and I'll explain how this came down. This is part of the an inappropriate attack on my entire beloved profession. My name is Dan Gaddy, and under penalty of perjury, I swear on and affirm that, 1, during the SAFE investigation, Operation Clean Sweep, and I'll explain how that went down, I was a licensed Oregon attorney who represented the majority of 27 chiropractors investigated for racketeering and allegedly maintained a dual rate structure when treating injured workers. None of my clients were found guilty of this malicious charge made up by SAFE. Now, what the dual rate structure consisted of, remember that previous slide where it shows that 67% of medical physicians didn't want to do workers' comp because of the additional administrative costs. Back in 1988, there was a CPT code. It was an office visit code, no longer exists. And that was charged by several offices. It's usually the high-end guys would charge that for the additional administrative burden, cost, staff time to deal with a workers' comp claim. I didn't do that. Most of us didn't, and I suspect it was these high-end folks that charged that additional. It was like $10 or $15 per visit for the additional administrative costs. That was then under RICO could be multiplied by a factor of 3, and that was the number that was published over and over and over again in the media, painting us all with the same racketeering mantra. Now, regardless, my recollection is that 2 or 3 of the chiropractors who could not afford to defend themselves agreed to cease their treatment of injured workers in the future, and their cases were dismissed. All of the other 27 chiropractors were ultimately not charged, their cases were dropped, or the doctors were acquitted. Now, I think, and I don't know this for certain, the 2 or 3 chiropractors he's referring to were there was 3 actual fraudulent docs. And this is how it went down. Dave Fulmer was the Attorney General, Republican, running for governor. In concert with SAFE, they went in with undercover investigators and went into these high-end offices. And what happened was they would go to the front desk and they would say to the front desk folks, posing as an injured worker, I injured myself unloading the company truck. When they got back with the doctor, they would tell the doctor, well, I told your staff that I injured myself unloading a company truck, but in reality, I was chopping wood this weekend. Then they sat back to see what the doc would do. Well, 3 of the knuckleheads went ahead and filed a workers' comp claim. Well, that's insurance fraud. All 3 of them, rightly so, lost their licenses. And we were painted all with that same brush. And this gives you the nature of the individuals that had such animus to my profession. 2, during the defense of these cases, it became quite clear that SAFE had significant animus toward the chiropractic community. I think it was actually one main individual. And the primary goal of the investigation was to completely eliminate chiropractic access by injured workers desperately needing the unique care chiropractic physicians offer. An example of SAFE's attitude towards this respected healthcare profession: during one deposition, the agent admitted that the acronym AFM Janitorial, which is one of the dummy employers that sent these investigators out posting as employers, the acronym AMF Janitorial stood for Adios, Mother, and I'm not going to say the last word. That's the nature of the folks that attacked my profession. Back then we had, 1988, we had 800, nope. I guess. Back then we had 824 chiropractic physicians licensed to 844. So 3 knuckleheads filed fraudulent claims, and they lost their licenses, and rightly so. 3 does not make a profession. So what have we been doing to improve the quality of chiropractic practice and to address the outliers in our profession? Everybody's got them. Well, in 1990, we got together, we produced what was known as the Oregon Chiropractic Practice Utilization Guidelines. I'm not going to go into all of it. It's basically what constitutes proper care, what does not. Then in 2005, Oregon Chiropractic Association went to the Oregon Board of Chiropractic Examiners with this proposed administrative rule under clinical justification. And it states as follows. I was the original drafter of this. Chiropractic physicians shall treat the patients as often as necessary to ensure favorable progress. Evidence-based outcomes management shall determine whether the frequency and duration of curative chiropractic care is, has been, or continues to be necessary. Outcomes management shall include both subjective or patient-driven information as well as objective provider-driven information. Now, the reason for this is we're treating them actively to fix them. Well, at what point do they fix it? At what point are they done? At what point do you deem them at maximum medical improvement? And utilizing evidence-based self-reporting psychometrics, fancy term for patients filling out their current levels of pain, visual analog scale, numerical pain rating box, and a pain drawing, which can indict themselves as embellishing and so forth. All of these are evidence-based. Combined with activity intolerance, the osseous low back pain disability questionnaire, or the neck disability index questionnaire, their function, activity intolerance, lack of being able to do certain things, and pain are 2 different things. Those have to show a progression of care. They can have a bumps up and down, but there has to be a progression of care. If not, an our administrative rule, you must either, if they're not progressing, you got to do 1 or 3 things. You got to change what you're doing as far as treatment interventions, refer them out for a second opinion. Is there something I could be doing that I'm not doing, or am I missing pathology? Or 3, stick a fork in them. They're done. They're at maximum medical improvement. You don't just continue to treat and treat and treat. This is part of our Practice Act. Outcomes management shall include both subjective and provider-driven information. Now, the provider-driven information is our examination findings, our objective examination findings. Those both have shown a progression of care, and when they plateau out, the patient is done. You don't just continue to treat and treat and treat. In addition, treatment of neuromusculoskeletal conditions outside the Oregon practice and utilization guidelines, that document I showed you before, is below, it may be considered contrary to accepted standards. Chiropractic physicians treating outside the practice and utilization guidelines, NMS Volume 1, Chapter 5, bear the burden of proof to show that treatment of or lack thereof is clinically justified. And then my last slide. So when do you do these evidence-based outcome assessments? At what point do you administer those? At what point do you re-examine? At what point do you determine it's their progression of care? And this we came up with when we've updated these practice utilization guidelines through the years, and this we did in 2017. And essentially, without going through the whole thing, it's every 12th visit for 6 weeks, whichever comes first. You must do these. If you do not, you fall below the standard of care, and the Board of Chiropractic Examiners could sanction you everything from a letter of reprimand to revocation of your license for repeat offenders. That's my story, and I'm sticking to it. Thank you.
Thank you very much for your presentation. Do we have any? Oh, Ryan, beat me to even finishing asking for questions.
Thank you, Co-Chair Strickland. I appreciate it, and thanks for that presentation. Just a clarification. So currently, as it's written, do injured workers have their choice as a physician when they file a claim? Can they treat with a chiropractor as it's written right now?
Yes. For 18 visits or 60 days, 30 days of time loss. And unless they're enrolled into an MCO, if the chiropractor is not on the MCO, and that's another issue, the panels are so small, if that particular chiropractor is not on the MCO, they lose control of that patient.
Okay. And can they be referred back to the chiropractor after the 18 visits or 60 consecutive days if they're with a different attending physician?
They can.
Okay. Thank you for that. I appreciate it.
The only problem with that, if I could follow up, is that animal doesn't exist.
I'm sorry, that animal doesn't exist?
There aren't any attending physicians, with few exceptions, that are willing to see workers' comp cases. The injured workers can't find anyone.
Thank you for that.
Other questions from folks? No. Ryan, you just took yourself off mute again.
Yeah, considering another question. I appreciate it, Co-Chair. Sorry about that. I'd be curious. I don't know if the data exists, but to see if we can compile data about how many chiropractors reach an MMI status within that first 18 days or that consecutive or the 60 days or 18 visits. I don't know if that data is mineable, but curious. Yeah. Curious to see how many people are making it to medically stationary status under chiropractic care within that time frame, if that makes sense.
Yeah. Time loss would be another thing to look at.
Yeah.
Time loss given at med clinics versus chiropractic clinics.
Yeah. Thank you.
I'm writing it down.
Okay.
Okay.
I see Evo has his hand up.
Yeah, thank you, Mr. Co-Chair. I was waiting. I don't have a question. I just wanted to kind of speak so much about SAFE. So again, for the record, Evo Trummer, SAFE Government Relations Director. First, I want to say, and we sat down with Dr. Saboe, it feels like a couple of months ago, and I want to say clearly, and I want to appreciate and express my appreciation. He has a clear passion for his profession and for his patients, and really nothing but respect for that. So much of what we've seen in the slide deck was from the 1980s. I love seeing Phil Kiesling, very young, in a headline of 89. I want to remind people how long 1989 ago is, right? The wall in Berlin fell. in the November of 1989. That is a very long time ago, and I'm not going to relitigate, if I may, sort of the 1980s. I want to follow up maybe what Ryan said. We don't see any, since Mahonia, any systemic issues if for patients getting or injured workers getting referred back to chiropractic care after the transition to an attending physician. So we are not aware of that at all. It is then a matter of a referral, just like anything else. Physical therapy, massage therapy, if you need an MRI or a specialist, it's a referral. And with that, thank you.
Can I respond to that?
Please, yes.
So we are documenting that occurrence of folks trying to get referrals back. In fact, there's one hospital physician organization, and it's not Samaritan Albany. They're great to work with, but there's another in the Portland metro area that will not allow the PCPs to refer back. They must send their patients to the OCMED clinic. And this just came from a doc yesterday, Portland chiropractic physician. Patients making great progress, but time has run out. Her primary care doc will refer her back, but the administration at the hospital physician organization there in Portland would not permit her to do so. She had to refer that injured worker to the local OCMED clinic, and she could not get in for 2 weeks. And we're documenting all these, trust me.
I see a hand up from Giovanna.
Yeah, I just had a few comments. I appreciate the presentation. I think from an injured workers standpoint, when I see this happen all the time, anytime a worker has to change attending physicians, they're going to have a delay in their treatment and oftentimes a gap in their time loss. And that's bad for employers. It's bad for workers. Workers are losing wages. Employers can't get people back to work, can't move forward with the claim without that. And that happens when providers expire in their amount of time that they can provide, and also when there's an MCO change. It's just very difficult for workers. It's very hard to switch doctors, and it's becoming harder and harder. I'd also say it's really hard for workers on the second 30 days of their deferral period. Dr. Saboe mentioned the 30 days for time loss and 60 days for medical services for chiropractors. And that's a real problem for workers because they get to that 30 days, they're not released yet, but a regular doctor won't see them. They say your claim's deferred, can't see you on your private health insurance, won't see you till your claim's accepted. So they have a 30-day period during deferral where they are stuck. I think that's a really big problem and an access to justice, access to medical services problem. And just more generally, we've been talking a lot over the last couple of years at this committee and in subcommittees about access to medical services. And this is a segment of providers who are there talking about increasing access to justice. So it's certainly something that we should consider in that overall discussion. Thank you.
I'm sorry, I didn't catch that last suggestion. You kind of tailed out. What was something we should look at? What was the last part?
I was simply saying, we've been talking a lot in this committee in general about access to medical services and availability of doctors to provide those medical services. So this suggestion is certainly something that we should consider in that broader discussion that we're having.
And I agree.
Great. I know we are just over time. Happy to entertain if there are any other very, very brief questions, comments. Otherwise, our thanks to Dr. Saboe for the presentation.
Thank you.
And with that, I guess finally on the agenda, we have March 13th, March 20th, both virtual meetings.